Good afternoon. Thank you very much for having me, and thank you for the introduction, Shannon. I have the pleasure of introducing our next three panelists. Lori Toscano currently serves as the Executive Director of U.S. Programs for Cure Violence. Lori has been working in the field of violence prevention for 20 years. Prior to joining Cure Violence, she directed the Safe Streets Baltimore program, the first Cure Violence replication site outside of Illinois for the Baltimore City Health Department. Lori has evaluated and assisted other global cities interested in adapting the Cure Violence health approach to violence prevention, including numerous sites in Brazil. She is frequently invited to present at conferences related to public health, juvenile justice, and criminal justice, including Cities United, Futures Without Violence, the U.S. Department of State, Inter-American Development Bank, and the U.S. Department of Justice. Our second speaker will be Dr. Kathleen Reeves. Dr. Reeves is Director of the Center for Bioethics, Urban Health, and Policy at Temple University. She is the inaugural Senior Associate Dean of the new Office of Health Equity, Diversity, and Inclusion, after having served as Associate Dean and Senior Associate Dean in Student Affairs from 2003 to 2015. Dr. Reeves is also a member of the pediatric faculty at the Lewis Katz School of Medicine at Temple University. The Philadelphia Ceasefire Program, which is based on the Cure Violence model and not to be confused with the Baltimore Ceasefire model, is housed within the Center for Bioethics, Urban Health, and Policy, and is one of several research-driven, innovative health-related projects directed at giving people who live in urban, distressed communities the capacity they need to be healthy. Our third presenter will be Dr. Daniel Webster. Dr. Webster is Director for the Johns Hopkins Center for Gun Policy and Research, Co-Director for the Johns Hopkins Center for the Prevention of Youth Violence, and Professor in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Dr. Webster is one of the nation's leading experts on the prevention of gun violence. He has published over 100 articles in scientific journals on topics including gun policy, violence prevention, youth violence, intimate partner violence, substance abuse, and injury prevention. For more than 20 years, Dr. Webster's research and policy analyses have helped to shape local, state, and federal policies on gun violence prevention. Dr. Webster's research and leadership have been particularly evident in Baltimore, where he advises the mayor's office, police department, and health department on strategies to reduce gun violence. He co-chairs the advisory board for Safe Streets Baltimore, and also leads the Johns Hopkins Baltimore Collaborative for Violence Reduction, a partnership between Johns Hopkins, the Baltimore Police Department, the State's Attorney's Office, and the Baltimore Health Department to promote data-driven innovation to reduce violence and improve police-community relations. In 2016, Dr. Webster received Baltimore City's Health Equity Leadership Award. Please join me in welcoming our panelists. We will have each speaker come up and present, and then we will have about 30 minutes for Q&A after the panelists conclude. So with that, I welcome Lori Toscano.
I gotcha. So I should probably ask, do I need to speak into the microphone? Oh, geez. This is very professional. I'm a little bit more low-key on the normal, so I'm going to stand here and try not to move around, but I really want to, just so we all know. So thank you all for having me. It's a pleasure to be here. I actually live down the block, so it's great to be in my own neighborhood. I didn't think about the fact that you all probably know a lot about Cure Violence. So I do have a few framing slides just to get us started, but really what I'm going to focus on are the lessons that we've learned to date, and really what it means to then take those lessons and translate it into this larger national and international work, which is kind of where we are right now as an organization. So Cure Violence began in the late 1990s. Our CEO and founder, Dr. Gary Slutkin, is a medical doctor and an epidemiologist who spent the bulk of his career working for the World Health Organization, working to eradicate diseases internationally, globally, pretty much everywhere under the sun. He returned to Chicago, his hometown, and started thinking about, what he was going to do next. And that's when he realized that violence was, the way that violence was being transmitted looked the same way as other diseases that he had been tackling, right? So in thinking about our framing, right, just our vision in and of itself, a world without violence is really the end goal, is really what we're all working at. And I'm gonna try and use the clicker in a way that makes it work. Am I? Okay, I can do that. Can I click? No. Can I click? There we go. I went backwards, right? So ultimately, in thinking about this work, we're thinking about primarily the work that we've seen in the communities that we're replicating the model in now is looking at community violence, right? So we know that other forms of violence are transmitted the same way. We know that exposure to one leads to the potential of being a perpetrator of other forms of violence as well. But what we ultimately know is that violence is a health issue. The problem with that, right, is that it's really difficult, even in this day and age, to convince people of that. So in thinking about violence as a health approach, we think that violence is a disease. We know that violence is a disease and that it behaves in the same way as other epidemics. And we know, based on the work that we're doing throughout the country, throughout the world, that treating violence as a health issue using the same epidemic disease control methodology has results. So really, this is the basis of the work that we do. And just to give a little bit of the framing around this discussion, right? So we know that it has the characteristics of an epidemic. We know it clusters the same way. So you see cholera on the left in Bangladesh, violence on the right in Chicago. We know it spreads like a disease, just like the flu, right? So flu begets more flu, right? The way that it's transmitted. We see the same thing with the spread of violence. And we know that violence is transmitted. You can see this cute little picture, right, where the dad is making faces, the baby is modeling those, right? So we know that violence spreads through exposure, through social learning, through norms. And we know it spreads from one person to the next. The great news that we always say, right, is that we know how to stop the spread of epidemics. So using the same methodology that the World Health Organization uses, we know that we work to interrupt the transmission, prevent future spread, and change norms. So the way that we do this in terms of cure violence, and as it's known here in Baltimore, Safe Streets, and in other places it's known by many other names, but in using a health approach, in terms of working to interrupt the transmission, we have staff that we've deemed credible messengers, so individuals that have influence in the communities that they're working in, that have the ability to work with those at highest risk for being a victim or being actively involved in violence. And they're able to work with individuals to provide new skills and new information, right? So it's the concept of being able to talk to somebody based on the level of influence and be able to tell them, I've been there, I've done that, or me, I grew up in this neighborhood. Sometimes it's a coach, sometimes it's a teacher, sometimes it's someone who's had the exact same lifestyle, but we're talking about interrupting it at that level, right? Interrupting it in the moment, and then in terms of changing behaviors, working more long-term with individuals to really think about how to respond to conflict differently, right? How to provide new skills and new information in a way that gets people to think that, if you're disrespected, you don't have to respond violently, right? There's a different way to respond. And then thinking about solving the problems using these this different way of thinking, but getting this information from people that they're more likely to listen to, right? So I've been doing this work or similar work for about 20 years now, or a little bit more than 20 years. And the kids that I've worked with historically, it would take me a really long time to build that trust, to get somebody to think, I'm going to trust Miss Lori, like, she has my best interest at heart, instead of thinking, what the heck does she know about this, right? She doesn't have the same life experience. She doesn't look like me. She's not from the same community. When we talk about the credible messengers that are doing this work at the community level, they have that level of influence and that buy-in in seconds. It would take me 6 months, a year. We have individuals who are able to provide this new information in a way that makes sense, and then to change these behaviors over time. And then we also think about changing the larger community norms. So what does it mean for a community to really be able to exercise social control over their own community, to really be able to think about doing things differently? And in a lot of the communities we're working in, these are communities where things have been done to them, right? So if we think about trauma-informed care and we think about asking the questions, what happened to you? You know, it's the same thing with these communities. It's not about changing who people are or making people take blame or ownership for the violence that's going on in their neighborhoods. It's saying that we understand what has happened to you, and now how can we work together as a whole to really change a community? So by doing these pieces of the puzzle, right, we're working to stop the transmission of violence so that it doesn't spread. So let me first start out by saying, in terms of lessons learned, I could be up here for the next week, easily. You know, I think that when we think about replicating a model, when we think about programming, when we think about intervention, when we think about prevention, when we think about all of these pieces of the puzzle, a lot of the times we fail to really take a critical eye at the work that we've done and really use the lessons learned to influence us moving forward. That's one of the main reasons that I ended up joining Cure Violence National. Was I appreciated the fact that it was an organization that really said we can be better, right? What have we done in the past that's worked? What isn't working? What can we change so that we're doing things in a way that makes sense, that we have the right partnerships, and that we're actually not only working to reduce violence, but to eradicate it? So, to start with, you know, everyone here in this room gets it, which is awesome. But when we talk about re-understanding violence, you know, it's a challenge. I travel the world, and I talk about violence as a health issue. And depending on who the audience is, some people are like, oh my gosh, yeah, of course, that totally makes sense. Other people have a really hard time thinking about it in those terms. Because historically, you know, especially like we're looking at this picture, which is forever and ever ago in our lives, right? We didn't experience this in our lifetime. But when we think about folks that were infected with a disease, folks that were sick, right? Historically, they would be locked up. Right? They would be condemned. They would be thought to be bad. They were evil. They had something evil inside of them. You know, and it wasn't until science came in and said, no, you know, it's this microorganism, you know, this is what's actually going on, you know, that people were no longer seen as being bad people when they got sick, right? So when we think about that in terms of violence, click, right? We think about it in those same terms, we think about the new language that's needed. And a lot of people struggle with this because historically, it's easier to say that violence is occurring because of bad people, right? Because of people that are doing bad things, people that are, you know, deemed to be not like you, right? Like not like me, not like you, not like other people who can kind of say, this isn't me, this doesn't affect me. And so it's challenging to think about it in terms of reframing how we think about violence. So with the dawn of violence as a health issue, with really realizing that there is a scientific approach that can be taken that's shown proven results, we also have to think about the new language that we have to be using. And people struggle with this, but it's catching on more and more, right? It's spreading, which is great, in a good way. Right? But we think about the way that we used to talk about it, the words that we hear every time we think about violence. You know, you think about what is on the news at night, right? These are the words that we keep seeing. These are the words that we have to move away from. But the idea of re-understanding violence, of thinking about it in a different way, is still a challenge. And it's one of the lessons that we continue to learn when we talk about this approach, when we talk about violence in a different way. But really what our goal is to stop talking about it in this way, to stop using these words, right? To really think about violence as a behavior and therefore something that can be prevented and something that can be solved. And so there's this concept of, you know, old view and the health view. So when we think about the old view, you know, it's really easy to talk about bad people or gangbangers, you know, talk about these isolated incidents in these specific communities. You know, how are we going to resolve this? We're going to punish people. We're going to lock them up, right? That's the only way out of this. Thinking about this as an intractable issue. But when we think about it from a health view, now we're talking about violence as a learned behavior. We're talking about negative norms, people that have learned norms that they've seen time and time again that are negative, but not that they're bad people. It's what they're being exposed to, right? That we know that it's a contagious process, that it's transmitted from one person through the next, and that we know that disease control methodology works, and therefore it's solvable, which is like the best news ever. Still challenging to convince folks of that, right? And so how do we frame this issue in a way that more people start to think about it in this way and therefore can approach this issue differently? So in re-understanding violence, right? So moving away from this whole concept of bad and good, right? Bad choices now, adverse circumstances that contribute to the likelihood of being engaged in violence. right? How violence is transmitted through exposure, right? Through the way that people, through learned behaviors. And we start thinking about science and health as the solution. And then by doing this, right, we're reducing the inequity and promoting an understanding instead of just going back to bad people and the way that we used to try to solve this issue. So in thinking about epidemic disease control methods, right? So I'm sure everyone in this room gets this. When we think about smallpox, right? We didn't think about reducing smallpox. We thought about eradicating smallpox. It's the same way with other diseases. What we're seeing in the implementation of this work, and I can speak specifically, to cure violence, when I go to a city and I talk about this issue and people are interested, right? And people say we want to do things differently. We really want to think about violence through a health lens. And so we start to think about what it will take. A lot of the times what we do is we start to say, well, we know that things can be expensive, so what if we just piloted like one small project? We pilot one project, we show results, there's gonna be tons of money thrown at it, we're gonna reduce violence across the city, and everything's gonna be great. It doesn't happen, right? We get stuck in one tiny site in a city, or two tiny sites. Sometimes it's 4, sometimes it's 5, but we're not thinking about it citywide. We're not thinking about staffing it the same way that we staff the World Health Organization and sending people out to prevent the spread of cholera. What we think about is what can we do with this small piece of the puzzle that we've been allocated, and then we expect that we're going to be satisfied with reductions. And how can we be satisfied with simply reducing violence? Our goal needs to be eradicating violence. Our goal shouldn't be that we've reduced it from 5 homicides in a community to 3, right? Our goal should always be 0, but we don't think about what it takes to get to 0, and we don't implement in a way that makes sense that that's gonna be our end goal, right? We think about reductions, we think about proof points, we think about making a difference that people are gonna get behind, that people are gonna see the value of this work, and then it's gonna spread like wildfire, and we don't see that across the country. There are some cities like New York that has really taken this issue, really promoted violence as a health issue, really tackling it in the way that other cities should, right? We're talking millions upon millions of dollars that they're seeing reductions. So there are currently 19 community sites in New York City. In February, not one site had a shooting. That's the level that all of cities should be thinking about, the way that we think about smallpox, the way that we think about other diseases. But again, in terms of lessons learned, I know I go into other cities and I'm like, well, we could do this, like maybe we could modify it in this way, maybe this staffing pattern would work, always, recognizing the fact that it's not enough. So how can we translate how we should be working on violence in communities the same way that we're thinking how we should be working on these other diseases across the world? Right? In terms of credible messengers, historically, we really focused on the role of the outreach worker and the violence interrupter. So the same way that we're thinking about community health workers. But what we've started to learn is credible messengers look differently based on who the audience is. So now, in terms of looking at a Dr. Satcher, looking at a Dr. Mary Bassett from New York, looking at Dr. Lena Wen from here in Baltimore, looking at Major Anthony L. in Kansas City, Missouri, who's now retired, looking at Dr. Stephen Saltzman, who is a trauma surgeon in Chicago. When we talk about trying to get people to understand this and to take it on as a health issue, it's not always who is the violence interrupter, right? I like to say we're all violence interrupters. What is our role in this work? What's the role that everyone can play? And how can we be communicating the need for health to take the lead on this issue unless we're thinking about credible messengers, not simply in replicating the model within a community, but in terms of how we talk about this, whether it's in a city, whether it's nationwide, how do we look to see who the spokespeople are? Oh, 5 minutes. Oh, I'm gonna fly then, Shannon, thank you. In terms of changing behavior, right? So we think about the work in communities. What I've seen across the country and what we've as an organization have seen is we're constantly in interrupt mode, right? If we're working in communities that are disproportionately affected by violence, a lot of the work that the teams are doing is interrupting that violence, mediating those conflicts, hearing about something's about to jump off and getting in front of it. But what does it mean now to really do that larger behavior change work? If we think about the World Health Organization, they had a COMBI, it's I can never remember what COMBI stands for, but it's in terms of what is the communication to change norms in a community, right? What are the small group sessions that we should be having? How are we working with the community at large to really change the norms in terms of sustaining our efforts, but also in terms of moving past constant interruption, right? Oh, sustainability, perfect timing. So a lot of the times this comes to funding, right? I think sustainability looks completely different in terms of the different ways we can think about this. We should be thinking about it in terms of that larger norm change, what it looks like to sustain reductions, to sustain hopefully 0 shootings and killings in a community. But what we also have noticed is a lot of the times people think, well, we've seen reductions, we've done our job, now we can go. We don't do that with any other disease. We saw this in Chicago. So Chicago's funding was cut. We saw this huge rise in shootings and killings occur. We know that we have to be able to sustain these efforts. We need to start thinking about what that looks like, right? Like maybe it's not 100% of X program or X model, but we need to start thinking about what does sustainability look like in terms of how do we fund it, how do we staff it, and then how do we make sure that we're actually changing behaviors and community norms in a way that will sustain efforts long term. Staff support's another key one. So this year we actually entered into a project with the Office of Justice Programs Diagnostic Center, because what we started recognizing was we were very focused on results, right? If we had reductions, if we showed reductions in shootings and killings, we knew that this model could save lives across the country, across the world. That's what we cared about. What are the results? What are the results? What we failed to continue to think about was we are chronically exposing our staff to these situations, and we're not supporting them in a way that makes sense. So what do we need to be doing differently to support the staff in this work? How do we think about trauma? How do we think about chronically exposing folks to violent situations with the concept that they are interrupting them, right? That they're getting in between these and solving these conflicts and preventing shootings and killings from occurring? And then how do we make sure that they have the support that they need? And how do community organizations and partners support staff as well, right? And support this work on a larger community scale. So that's the work that we're doing right now, which honestly is a huge lesson learned. We didn't think about ourselves in terms of even reentry. A lot of the folks that are staff members across the country are returning citizens. What does it mean in terms of best practices from that field that we should be taking and using to influence and inform the work that we're doing? Health systems framework, right? What's the bigger picture? Huge lesson learned, right? We're doing these like single epicenter target area approaches, and we're not thinking about the role of health as a whole. What we need to start thinking about is what does the larger systems framework look like? And there's a larger national movement that is currently underway, and Shannon Cosgrove, who is here, also from Cure Violence, is leading part of that effort in collaboration with a lot of other agencies and organizations throughout the country. But what does it look like if we're talking about working on violence using a health approach? What does it look like in terms of a systems approach? Right? What's the bigger picture look like? What are the roles that health should be playing in all of these different arenas? And that was a huge thing that honestly, I think people started talking about it early on, but started really, I think we kind of got stuck again in the work itself and not looking at what is the larger system to really eradicate violence at the community level, at the city level, and then at the national level. And then, of course, the importance of partnerships. Right? We know that violence is a social determinant of health. We know that it affects other social determinants of health. We know that reducing and hopefully eradicating violence allows individuals the opportunity to focus on these other areas. But what we failed to see early on was what do those partnerships look like? How can we be working with folks that are working in these other areas to really take this and see the results at a larger level, at a grander scale? And so that's a big piece of the puzzle moving forward. But again, I think is a piece that we still need to figure out. And then the same thing in terms of what we've tried so far is, so we are a part of the Healing Justice Alliance. which is a collaboration between Cure Violence, the National Network of Hospital-Based Violence Intervention Programs, Youth Alive out in Oakland, and Berkeley Media Studies Group. And we're working with 12 sites throughout the country on a Supporting Male Survivors of Violence grant through the Office for Victims of Crime. What does it look like in terms of supporting male victims of violence? What does it look like in terms of masculinity? What does it look like in terms of culturally appropriate services? So it's taking what we know at the community level in terms of the work that we're doing to reduce violence, but actually trying to make an even bigger impact through partnership. But this is just, in my opinion, just the tip of the iceberg. I think what we're trying to do, and what's so interesting in the work that you all are thinking about, is what does it mean to take these lessons learned and translate it into broadening the approach, into broadening the partnerships, and into actually eradicating violence by using health approaches and by using partnerships in a way that makes sense and is acceptable throughout the country, in the way that we talk about it, in the way that we view it, and then obviously in the way that we treat it. So I am going to, I'm sorry, I think I went over, sorry. I am going to pass on over to Kathy, who's going to talk about some of the specific work at the city level. And I'll pull you up. It's that guy. You're welcome.
Well, thank you, Lori, for a great introduction, and thank you very much for asking me to come and sort of share our story. So what is translational research, or the opportunity to translate research into action, other than to take a model like this and really implement it in a place? And how does that go well? How does that not go well? What do we have to do to sustain it? So what I want to share with you is just a little bit about our story. So using ceasefire is confusing because not only is there a Baltimore ceasefire, there's a Pennsylvania ceasefire that has nothing to do with us, and then there's Philadelphia ceasefire. We kept the name, honestly, as part of our community engagement dedication, because our community didn't like Cure Violence. They didn't like thinking they had a disease. So they felt more comfortable with the ceasefire term, so we kept it. So our story really begins a little bit before 2010. So we had a Secretary of Health, Calvin Johnson, who started to work with the folks in Chicago looking at violence in Pennsylvania. Of course, Philadelphia we got to win that one as having the most. And his chief of staff, her name is Marla Davis Bellamy, they worked to bring Cure Violence into Philadelphia. So they got funding from PCCD, which is the Pennsylvania Commission on Crime and Delinquency, and they were able to start this program right when Governor Rendell was leaving as governor. So Calvin decided he didn't want to go that direction, so Marla's sitting there holding this grant with no place to take it. So she came to Philadelphia and told people, hey, I have money. Even though she's bringing money, when she said what she was doing, it wasn't like people were standing up saying, yes, yes, please come. If we have an NIH grant and I want a job and I say, gee, I'm going to bring it with me, everyone says, of course, that'd be great. That didn't happen because people weren't really convinced about what this was. Now, this is just a map of Philadelphia, and I just want to show you. So the 22nd Police District, that's where where Temple University sits. The 39th is where the medical school sits. I'm not quite sure why Philadelphia can't number in order, but apparently we can't. So in the 22nd Police District in 2010, the statistic we kept quoting, again, it's facts, if you were a 13-year-old male of color in the 22nd Police District in 2009, you were more likely to get shot than you were to go to college. So obviously that's one of those statistics that everybody, when a light is shown on it, they react. So we took that knowledge, the terrible charts of how awful it is, of how many people get shot, all of those things, and took it around to different partners, is what Marla started to do. She graduated from Temple Law. She started in the law school. Though the law school didn't bite, which I think we're actually quite, in retrospect, happy that that didn't happen. And just sort of by luck, because Calvin Johnson and the current dean of the medical school at that time were friends, Calvin convinced John Daly, who was dean of the medical school, to talk to Marla. So Marla went and met with him. And John thought, okay, we'll give it a shot. John's a surgeon. She convinced him it was a public health issue. And the other thing that really helped us, so do all of you know that if you're a not-for-profit hospital, you have to now, by IRS rules, do a needs assessment, right, in the community? Have any of you ever seen those needs assessments? If you see the real needs assessment, at least for us, every year, the same two things are at the top. And every year, hospitals go to number 3, because number 3 is either diabetes, congestive heart failure, or stroke, or one of those things. Because the first two, everybody would say, well, that's not health. Even though our community partners would answer the question, what's your biggest health concern? Number 1 is violence, and number 2 is opportunity for their kids. So I think getting health systems to start to see those as health issues is really, really important and really helpful, because the community already knew that. So we have these things happening. So we decide to start and move this program into our medical school. And the other thing we had going for us, we're right in the middle of the hotspots. And Temple historically has been really committed to the community. Just a little aside. Does anyone know why we're the Owls? So we're called the Owls because the founder of Temple University founded the university to educate immigrant families. And none of those families could go to school in the daytime because they were working. So that's why we're the Owls. So it's a community-integrated university. So that gave us the ground roots partner, because I'm sure Shannon and Lori will agree, you can't do this unless you have really the community invested in it. We can't dictate it to the community. The community has to come to it on their own. So with those things in mind, we start looking at, okay, we're going to do this. We need credible messengers. We need to turn folks who are returning citizens from prison into healthcare workers. So sure, on the 30,000-foot view, that looks great. In the Human Resources Office, that didn't look so great. So one of our biggest problems to start with is, how do you hire these folks? What do you have to go through now to even get a job in a hospital? And how many jobs are totally, oh, sorry, you can't have it if you have a positive criminal background check? So you can imagine what the kind of looks that we got whenever we started saying, okay, yes, we want to recruit someone because they were in prison to come and work in our hospital. But we persisted. And I guess the first lesson here to learn is you just have to persist. Sometimes you just can't take no. You just keep going and going and going. If you're really going to translate a finding like this into action, you've got to just keep pushing. So we were able to get folks as part of the academic community. John put it in the Center for Bioethics, Urban Health and Policy, because we were a unique center, where we were an academic center dedicated to health equity, dedicated to research around health equity. We were also a center that understood and taught about why Philadelphia looks like it does. A lot about what Lori said. North Philadelphia is not a collection of bad people with bad problems. It's not about what's wrong with you for us. It's about what happened to you. And if we look at people as what happened to them, then we understand that things like race isn't a biologic issue. It's a cultural issue. That institutional racism and redlining and how North Philly came to be is more about what happened to people and much less about people's internal abilities. So with that said, we could concentrate this in an area like North Philadelphia, understanding why violence is there and why it's not around the Liberty Bell. So the gentlemen that we have had the opportunity to work with have been amazing. And one thing we always teach, people want to be healthy, people want to be successful. Everybody wants that. And if you give people the opportunity or the capacity to do that, then they generally do rise to the occasion. But we had to spend a lot of effort on supporting these young men and women. We had to understand that lots of bad things have already happened to them, and they need trauma-informed support. And they need to have some sense of sustainability and security. You know, academic medical centers, we run on grants. Security and sustainability is a moment-to-moment venture. But we have to help them feel our commitment to them, even though funding can be challenging. So those were really important places for us to start. And then we really had to look at our partners. So we've got the community, and we are continually working with that. We've got our outreach workers. Obviously, law enforcement matters. I do believe we were lucky in that the Philadelphia police were actually, I think, a little more ahead on ideas of community policing. Philadelphia is a city of neighborhoods, and the police are still assigned to neighborhoods. Charles Ramsey, who was the police commissioner at the time, who's been on President Obama's violence task force, was committed to he understood the connection between officers and neighborhoods mattered. So another example of how systems, if you're going to translate something, systems really matter. Because if we have a police force where people aren't connected to their neighborhoods, then the likelihood of this working is going to be much less. So we were fortunate to have champions, and you'll hear that word a lot when these guys talk about cure violence. You need champions in all of these sectors. So we had champions in law enforcement. It was really helpful. Then we had to, so our first grant comes from the state, not a long deal. We have to move this forward. The money, all the money coming towards these programs was not coming from health. It wasn't coming from the CDC. It wasn't coming from the National Institute of Health. It's a shame, but it wasn't. It was coming from the Department of Justice. And most of these Department of Justice grants don't go directly to institutions. Most Department of Justice grants go to cities or municipalities. So we had to partner with the city. And we so wanted to be in the Department of Health. We still want to be in the Department of Health. We want to be on the health side of the city, and we can't get there. We're still on the criminal justice side. We're in the managing director's office for safety. But that's where we started. So we were able to partner with the city. They gave us a shot. One of the reasons they gave us a shot is because there's a huge institution behind us. You know, the Temple School of Medicine and Temple University, going to the city with that was a lot different than going to the city as a grassroots community organization. That gave us credibility and gave them an opportunity to give us a little bit more credibility. However, when you partner with cities, you also have to realize politically cities care about results, but they also, in the immediate, they care about making people happy in the immediate. And most violence prevention work hasn't been done academically. Most violence prevention work has been done as community grassroots organizations, and nothing has been measured. And all of Philadelphia's violence money has gone to that up to this point. So we talk about the Philadelphia Anti-Drug and Anti-Violence Network, YVRP, or Youth Violence and Crime Reduction Partnership, Mothers in Charge. These are very well-meaning, great people who really got a lot of money, but never had any results. And then we bring this, and there's never more money, so it ends up that we took money from them. So in the translation of this, you have to think about that. So we have to work really hard to find evidence-based ways to help these groups and well-meaning people make an impact. And we're still working on that. That's not always easy. We can't go in and say, you know, if you just did it this way, then it would be better. We have to help them see that. So another big part of translation is understanding who were the stakeholders before you got there, and how are you, you know, there's never more money, there's reallocated money. So that's the framework. So we have now funding for 3 years, and while we're working towards that 3-year funding, this is Mayor Nutter, who's now the mayor of Philadelphia. He puts forth Philadelphia's strategic plan to prevent youth violence. And all those groups in the previous slides are part of it, but we were fortunate enough to be asked to be part of it as well. So we start meeting with these folks, we start talking about what all of this means, and we start studying. They want to study it. We convince them results matter. So they make this map of the hotspots of violence. So there's our 22nd again. So you can see right around where Temple is, we got lots of red. And then South Philly, around where Police District 17 is the other big area. So they decide, okay, we're going to take two big models, one called focused deterrence, which is a law enforcement model, and one called ceasefire. And we compared those as part of Mayor Nutter's strategic initiative. And these are the focused deterrence. Have you guys heard of that before? The Boston Miracle, yeah. So they actually were called ceasefire at one time too. Everybody's called ceasefire at one time. And it's really important to invest in results in your community, not just depend upon Gary and Lori and Shannon's results. So we did the study. We compared ceasefire neighborhoods to controls that didn't have ceasefire in them. We have seen 2.5 fewer shootings per 100,000 people, per 10,000 people per month. If we did expand that, so show the politicians what this would mean. If we expanded that result throughout all of North Philadelphia, that's 400 plus fewer shootings. A conservative estimate of how many healthcare costs go into one shooting victim the year they're shot is $36,000. If I translate that into 400 shootings, that saves $14.5 million to healthcare costs. It's most importantly about humanity and keeping people free from this disease. But here is a great argument to talk about sustainability. So Mayor Nutter leaves. Mayor Kenny comes, still very committed to violence prevention, but he's an ex-firefighter. Now, it's important for us to know these things because he's moving over to that law enforcement focused deterrence way. We need to continually really be in his face, letting him know these results, because he wants to be able to stand up with his constituents and give results. So now, the one thing about Mayor Kenny, though, that's really good for us is he restructured government and put health and public safety together. So now we're really starting to talk about moving our results into health. And we also, Mayor Kenny's other big initiative, if you've heard anything about this, is schools. He's all into community schools. He's all into changing education. So if we want to be relevant, we need to move into education. I'm a pediatrician, so it's easy for me to think that way. So this is a picture of Simon Gratz High School. It's a charter high school. Ceasefire has 3 major different models, or cure violence: the street-based, hospital-based, and school-based. So we took the school-based model and put it in a school and measured. And we've shown decreased truancy. We've shown decreased level 3 disciplinary acts in that school. So we've taken that to Mayor Kenny, and we've taken that to the other folks within city government. And what we've put to them forth now is a plan that advances ceasefire, a street team around a school, a team in the school, and commitment from the university to create that school as a trauma-informed school, and to move it that way, sort of in response to the direction the city was going. And then we talk to the health insurance payers like AmeriHealth, and we say, look, you could save $14.5 million, and to do it would cost you less than $4 million. We go to the Chamber of Commerce and say, just think of the businesses, of the Business Plus that you could get if there was less violence down Broad Street. We still have to look at our NIH, NIJ, CDC, and that's supposed to be SAMHSA grants. And foundations, you know, foundations love these stories. If you can get a good storyteller in front of a foundation, then they want to do good things with, you know, that's the job I want, actually. I want to run a foundation and give away money. Everything has to be trauma-informed. And then all of this together, go back to the city and say, see what support I have, put me in your budget. You should have skin in the game too, otherwise you're not going to get any credit. So I'll let you know if this all works, but we're confident that we've got funding moving forward for a bit, and we're a player. We're someone that the city turns to. So we just wanted to share with you an example of taking these wonderful results that are local as well as global, and how do you really enact them into a city or a community in a way that can be meaningful. So that's my story, and now I think I'm turning it over to somebody. Oh, and cost avoidance, don't forget cost avoidance. I'm turning it over to Dr. Webster.
Do you want to? Hi, good afternoon. Oops. Sorry I got here a little late. I just came in from Denver. What I want to do is I want to talk about basically the last decade in Baltimore and my experience working with both generating evidence relevant to the prevention of gun violence and trying to apply that evidence. It's Baltimore, so it's not a pretty story, but there are some successes, some struggles, and hopefully there's something to learn from there. Just use zero. Okay. All right. I'm going to skip a couple of the initial things. I just sort of wanted to, of course, acknowledge that in a city like Baltimore, we got a lot of things that we're struggling against that are very relevant to why we have an unusually high rate of violence in the city. This simply is, you know, we've got a lot of lead. We're dealing with a lot of systems that are struggling, both health and education as well. A huge problem that we face is we have a lot of vacant buildings, a lot of deterioration, and the community is greatly affected by violence. It's a rather complex relationship because violence both creates the vacancy, people leave, but then the vacancy also creates environments that facilitate violence as well. So my focus, while some of my work is focused on you could call it behavior change, I'm also greatly interested in environments. So I want to acknowledge these constraints. One of the strategies that the city is working on right now is something called transformation zone. Shani's involved with that work as well. But in these areas, we're trying to look at what a variety of city agencies and their partners, neighborhood partners, can do to address violence. Again, vacant dwellings is one of those things. And there is some really great evidence from Philadelphia and some other cities of what you can do in some of these type of environments. One just has to do with greening. This is Charlie Brandis' work showing that simply cleaning up and getting rid of transforming areas into more environments that signal that people care about their community can actually reduce gun violence. And this is actually a controlled randomized trial evidence. Similarly, they've also tried relatively low-cost ways to secure abandoned houses, and also in a randomized trial found incredible returns on investments, these changing the homes in this way. reduced gun violence by 39%. Pretty astounding. Of course, Baltimore has a huge drug problem, and as long as I've been working in here, which is roughly 25 years, when you talk about violence, and particularly gun violence in Baltimore, people will connect it to drugs, the use and sale of drugs. We have a long history of approaching our gun violence through principally drug law enforcement strategies. Available evidence suggests that this doesn't work. In short, it actually more commonly, the more traditional forms of drug enforcement tends to actually cause or create disruptions in illegal markets that gets worked out in shootings. So I want to talk a little bit about some of the collaborative work that we're doing in the city and have been, some more formally in something we formed in January of 26 called the Johns Hopkins Baltimore Collaborative for Violence Reduction. We work very closely with the police department and state's attorney's office separately in other ways. We work with the health department and particularly with the Safe Streets program. I serve as co-chair of the advisory board as well as been working on evaluating that intervention for the past decade. So what we're trying to do with these efforts is, as I indicated before, trying to advance more evidence-driven ways to reduce violence in Baltimore. We set out some very specific projects for, you can call them reforms in how we go about our policing. So one strategy, the other strategy that I focused on was drug law enforcement, but gun law enforcement also is quite relevant in Baltimore and other cities. And one strategy is specialized units that go into the hotspots for shootings with special trained detectives to look for individuals illegally carrying guns, sometimes with intelligence on who those individuals are. A combination of hot spots, hot people, hot times that these efforts are deployed. There's a great deal of debate about this style of policing right now. When it is done improperly, it is very counterproductive. It can make for distrust in community that actually is counterproductive. The available evidence, and much of this is old evidence, consistently shows whether this sort of approach does reduce shootings. However, in New York, when it was applied in a much broader way in what people now refer to as broad stop and frisk, it did not appear to the best available evidence to reduce violence, and again, caused actually more challenges. Kathy mentioned a strategy called focused deterrence. This is a strategy that is associated with law enforcement, definitely sort of grew out of criminology. The best way to, in my mind, deterrence is prevention, though. It's sort of how you use your law enforcement resources. And what they try to do in this approach is to, actually in a similar way that public health does, is sort of look at the high-risk individuals and try to change their behavior. The goal here is to get them to stop shooting with a variety of different ways to try to influence their behaviors. And key to this is communicating those risks of, if they don't follow the rules as it relates to violence, that there are consequences, but it's not the message only coming from law enforcement, it's coming from community as well, pardon me, and the offer of services to help individuals get on the right track. More recently, and I think it's a very important phenomenon or change, is that fundamental is a demonstration of, we're going to go about this in a fair way, something called procedural justice is key to this. The evidence on this is rather remarkable when it's applied directly to gun violence. Pretty consistent reductions, and they tend to be pretty large. The same sort of strategies, however, apply to try, where the behavior they're trying to change is to shut down illegal drug sales. There's one success story talked about in High Point, North Carolina, but there's been a number of attempts to replicate that, and none have found any reductions in gun violence. Lori's already educated you about the cure violence approach. I don't need to cover that. But I want to just sort of walk you through what has happened in Baltimore on all of these fronts, using a variety of these strategies. And a lot of these efforts began kicking in around 2007 and 2008. Some on the law enforcement side and some as Safe Streets on the prevention side. So our then Commissioner Fred Bielefeld very explicitly turned the steering away from focus on drugs and more on, in his words, bad guys with guns. Basically, we've recently completed some analysis. We looked at Safe Street sites applied over the past decade, the hotspots gun units that they call VISAS here, Violent Crime Impact Section. They were shut down in 2012 because of a lot of bad behavior. And we had a similar problem here with officers federally indicted. Basically, these are stories of evidence-based approaches that can, if done wrong, can really, pardon the pun, backfire. Ceasefire was the focus deterrence strategy. And here's generally what our trends look like. We had some very early success in reducing the homicides and non-fatal shootings in the cities when some of these initiatives got going. But of course, we stalled. And then more recently, violence, these only take you through 2015 in this graph, but it's not going down, it's going up. I just want to give you a flavor for the direction of drug law enforcement, how that's declining over time here as well. And more of the rest now focus on guns than drugs. Well, not relatively speaking, but in terms of trends. So what we found is that Bielefeld's shift towards guns was associated with significant reductions in homicides and shootings. Had some success under the current Commissioner Davis of 23% reduction in shootings. Safe Streets applied, this is an average effect, and an important point I want to make is on average we've had a lot to celebrate, 27% reductions in shootings. The effects, however, have been uneven. Not all sites have experienced that type of success. The hotspots gun units associated with a 20% reduction. Drug law enforcement, very complicated picture. Shani is very key in helping on this work. We saw when you have a lot of arrest for drugs in an area, there tends to be more shootings afterwards. However, when you have more, what I would say, somewhat more strategic approaches to arresting and prosecuting the most violent individuals for their drug crimes, that at least has a temporary protective effect based on our evidence. So the directions that we're trying to encourage, but it's hard, is getting better results when someone is arrested with a gun charge. We have not a very good conviction rate, and then when they are convicted, even repeat offenders not getting much consequences. So those are things we're focused on. Changing our approach to how we enforce drug laws with a more harm reduction model. And then with Safe Streets, most of our struggles is to keep the funding going. I think we're going to be successful for the coming year. But really, my vision anyway is that we have a much larger footprint and perhaps with more complementary strategies. I think it's a lot. We're asking a relatively small number of people to create a lot of change by themselves. So what I feel like my role as co-chair of their advisory board is we need to get them supports rather than just say, go work miracles in really challenged neighborhoods. Let's actually support them better than we have. And we can talk about that some if you like. So that's what I have on my quick journey through the last 10 years in Baltimore trying to address gun violence.
I would like to ask our three panelists to come join us in the front for our Q&A section. And Eric is in the room with a microphone, so does anyone have any questions for any of our panelists?
Okay, so I have several questions, but first I want to thank the panelists for those great presentations. And so not to take up too much time, I will try to be brief with my questions. First question is, are you aware of any efforts to move a bit more upstream in terms of the initiatives that are being put forward? Because I think right now we are in a position where we are being more reactive and trying to change behavior of individuals who have long ingrained histories, many of them who also suffered violence themselves, which then translates into this cyclic sort of a process of violence. And so I'm thinking moving upstream. That's number one. Number two, along those lines, with the incredible rise in gang violence that we are seeing, and I'm thinking particularly of MS-13, and the number of young people that they are attracting who are now in that type of lifestyle, what might we need to change or tweak in terms of what we are currently doing to try to stem that tide? And so I do have other questions, but I'm going to just leave it there and give some other people a chance. Thank you.
So it's a great question. Of course, we've been focusing in our conversations way downstream, as your question implies, and you're absolutely right. That's what gets our attention, and of course, there's a lot of work that's been done in schools in Baltimore and elsewhere. A lot of that driven by very solid research at this school, particularly in the Department of Mental Health. There is success in anti-bullying programs and some other sort of, sort of social skill focused type of interventions. How widely they are applied, honestly, I couldn't say. I don't know if anybody else in the room can speak to that. I think it's useful to think about this in a slightly bigger way. I wanted to allude to some neighborhood conditions when I opened that conversation, because I think even with the school-based programs, we asked a great deal of those programs, not fix the variety of things that are facilitating violence in these neighborhoods, including environmental lead, among many things. And we do have some successful strategies that we can translate usually into changes in attitudes and to some degree in behaviors. But a lot of times, those are the examination of the effects aren't examined long term. So you're saying up front, again, we're probably all creatures of our funding streams, right? So someone gives you a grant to do something in early elementary, and okay, it's a 1 or 2 year grant, and you'll say, wow, look what we did. But what about longer term? Part of mental health, at least I know in the good behavior game research, has found that those changes actually went well into young adulthood. It didn't eliminate violence and some related problems, but it did those approaches with better behavior management, both at the classroom level and trying to help parents as well, can have lasting impacts. But I really think as public health people, we should be thinking more than how do we affect, the attitudes and behavior of children, and think about how can we create conditions for them where being nonviolent is easy.
So I agree with everything that Daniel has said. I think that moving into the schools, as we're trying to do in Philadelphia, is another opportunity. There's lots of programs, but again, as Lori alluded, what we do is we do a little program here because that's funded, but we ignore this part, or we do a little thing over there. What we're trying to do is take a neighborhood. So there's a school right next to us off our campus called Bethune. It's 700 kids, K through 8 school. So the proposal we're sharing with everybody is to put a ceasefire, a Cure Violence Street team around that school, put a team in the school, and then create a trauma-informed school. And then see if we can, you don't have a safe school if you don't have a safe neighborhood. There's great literature that not only can you not learn if you're not safe or you're experiencing trauma, but you all know about ACEs, right? Adverse Childhood Experiences, and that was reproduced in Philly, where Bethune sits. 45% of those parents have an ACE score of 4 or above. So it's working with the parents, it's working with the kids, it's trying to do all of that. And that all sounds great, and then you're gonna go to a funder and say, so you're gonna have results from me in, 25 years? That's not gonna help me. But one thing we're putting in with it, which doesn't seem to fit greatly, but I'm hopeful to be the funding source, is an asthma program. So there's also 45% of those kids have asthma. And I say these numbers so much, so I have them so set in my head. Every child whose asthma is not well controlled costs their insurance company $5,440 a year. Less than 20% of the kids in Philly are well controlled. If you do that math again, there's over $400,000 conservatively of savings in that one school for that insurance company. So I just think we have to be creative at putting these things together, and then, the studies that have made a difference in medicine, and I think in public health as well, the Framingham study or the big league studies, they're studies over 20 years. We aren't investing that kind of time into our marginalized inner city communities like we did in Framingham, Massachusetts. So we have to creatively get to that point, and I totally agree. It has to be downstream. It has to be multiple different things focused on one geographic area to create a portable, successful program.
And if I could just chime in with
I'm
that.
sorry,
Oh, that's
before you
okay.
go, no, thank you for clarifying that, Kathleen, because I certainly didn't mean just a school-based program. You've got to have those other supports in the community, et cetera. So thank you for that clarification.
Right, and I think that's exactly what I was going to say, right? I think that's what speaks to the need for this larger health systems framework, right? What does it mean not only across prevention and intervention, but what does it mean in all of these pieces in which the health field can really work at addressing violence through a health lens from early childhood all the way through old age, right? Yeah.
And then the second part of my question about the gang violence and anything that we might need to do a little bit differently in terms of our strategies.
I think specific to to Cure Violence, the model, right? When you're thinking about a specific gang or the way it looks like in a specific community, it looks differently in the U.S., city to city. It looks differently outside of the country, right? In terms of who the credible messenger is. So that's the really big important piece of the puzzle, that if there is a group that is in a certain area that the bulk of those that are most affected are gravitating towards, well, then the credible messengers needed to work to interrupt that, right, and to work to provide the new skills and new information need to look differently. So you have to get the right people in order to kind of change the interest in going towards that lifestyle.
Thank you so much for a wonderful panel. My name's Adeline Alchin. I'm a public health analyst at the Educational Fund to Stop Gun Violence. I had 2 questions. My first one was about the credible messengers, and I was curious if they're trained to ask about access to firearms? And if so, what do they do? Given that you said many of the messengers are previously convicted of felonies, they can't necessarily hold on to those firearms. So do you have opportunities to work with law enforcement to offer immunity if they want to hand over any firearms they own? So just curious about kind of the technical details of that. And then also curious how these types of models could be used to work also to reduce intimate partner violence or suicide.
So I would say a couple things in terms of the access to a gun. It's a little bit challenging. It's challenging in terms of the way that the folks that are doing the work on the ground talk about that issue, and really have conversations about not only access but turning it in, that type of thing. And so we've had a few of the programs throughout the country have done kind of the safe drop, right? Being able to say, like, there's a location that you can drop this off, and and that's the way that it's done. Is it the same across the board? No. Is it still challenging in terms of a turn-in or in terms of having that conversation? Yes. Really, the work that the credible messengers are doing is more of the how do you solve a conflict without the use, right? So almost moving away from even talking about access or the weapon itself, but more talking about the need to not use it, right? A different way to respond. Even in terms of thinking about how someone is going about their day, right? Like, what could you do differently so that access or having a weapon on you is not necessary? So it's more in that type of work. I'm sure someone else has something to say about that. But in terms of the translating this type of methodology to other forms of violence, actually, yes, it's actually going on right now in terms of looking at not only suicide, not only domestic violence, but also countering violent extremism. So looking at all of the different forms of violence and using the same methodology in a way that makes sense, right? We haven't piloted yet. I know there's some really good work that's going on throughout the country in terms of using a health approach, but we're also working on the adaptation now.
I just add very briefly that in many instances, the individuals that violence interrupters are going to interface with, try to resolve conflicts, many may already have a firearm, and my understanding of how they handle those situations is very consistent with what Lori just said. There are situations, however, of gun sharing that occurs, or when a conflict happens, someone gets in a fist fight or something. A lot of people believe that, like, if you're ever connected to gang screws or whatever, that you always have a gun with you all the time. Wrong, not the case. But usually you have social networks who can supply you with a firearm. And I know when they're trying to interrupt these conflicts to prevent shootings, in some cases, what their job is to try to convince someone not to arm someone when they're really mad. And I think that should be one of many strategies that they're using to, it's a harm reduction approach. Conflicts are going to be there. How do we manage them in a way that reduces lethal consequences?
Thanks. So one of the running themes of this of the conversations today has been like, this is all very informative, very interesting. How do we apply that to the environment that we're in now, right? So in an environment where the most public approach to gun violence is to literally send the National Guard into Chicago, how do you see this moving forward? I mean, the three of you have obviously been very successful with these programs and your research. How do you sell these programs in this environment to the people that are going to be making decisions?
I'll start, and then Lori. Without a doubt, it's a challenge, and I think being equipped with good data and evidence, of course, is pretty central. My experience is that our research showing efficacy of safe streets have saved their butt more than a few times when other people would say, well, let's just take this and put it in the fire department, police department, or something else. So having good evidence is certainly key, but that's not the only thing. I think one thing that could be sort of in the favor of prevention is that we're at a stage right now where we're really kind of re-examining law enforcement, everybody except our Attorney General anyway. And I think that's a good and healthy thing. I'm certainly, I think in order to address gun violence, you have to have good law enforcement. And there are a variety of pressures for them to adapt, not only into doing things that work, but doing things that basically that the citizens want. I just think, at least in most urban settings, there's less tolerance for a lot of stuff that police used to do in the name of public safety. Again, we don't have a strong U.S. administration necessarily to support all of that, but in many places it's not necessary. I don't think it's necessary, honestly, in Baltimore. I don't think it's necessary in Chicago. I think that the politics and such of those places are, we're looking for new ways to address this problem that both reduce violence and minimize or reduce as much as possible the overuse of law enforcement.
You go. So I actually think the healthcare world mirrors that right now. You know, healthcare is all over the news. It's not fiscally sustainable. Everybody's got that. I mean, we live it. We're an inner city health system that doesn't have the largest of endowments. You know, if the ACA goes away, there's a wonderful New York Times article about us. We're in trouble. So there's no doubt at all that health equity saves amazing amounts of money. Health equity cannot work without getting rid of violence. That's also very true. You know, people quote how, oh, the U.S. isn't the best healthcare system in the world anymore. Pockets of it absolutely are. The reason we fall so far in the World Health Organization is because our standard deviation is so large. You know, there's a 20-year lifespan difference from almost where my office sits to the Liberty Bell. You can judge someone's lifespan by their zip code. Those are unacceptable things and have nothing to do with someone's biology and completely to do with someone's environment. We're not going to make changes on so much, whether it's lead or asthma or access to good food or exercise or any of it, until violence is gone. It exponentiates every other social determinant of health. So we have to take our numbers, not just that 30,000-foot view. We have to show them, you'll save $14 million, and it will cost you so much less. Healthcare is so bad at not doing that. We don't invest up front. Everything's reactive billing. We have to convince people that Medicaid and Medicare isn't just about let's bill for this. If you're really going to do prevention and really going to give people the capacity to be healthy, you can't just pay for someone's mammogram. You have to give them the capacity to prevent it and pay for those programs up front and show that that's money savings. I do believe that argument will work with insurance companies and with government, but it's not universal enough. Physicians are horrendously awful at political advocacy. You guys are better. So we just have to get that message out there, I believe.
I'm just going to say one other thing. Cure violence, I think it can be more sustainable than it is. I'm talking about in a sort of political, fiscal sense, sustainable. If it was not as underground as it is, that it had more visible connections to community and things that we value. And I think the interrupters are fantastic. They do heroic work. But if they're not recognized and if they're not connected to other institutions in our communities and so on, they're not going to get that support. And they're just sort of, oh, those are those guys hanging out with the rough crew over there, right? And how do you rally support for people that they don't know who they are? They're kind of faceless and kind of underground. So again, in what we're trying to do in advisory board is try to encourage both the community-based organizations that are running the Safe Streets program as well as the city to bring these guys and gals out front a little more, to show who they are, what they're doing, and even, you know, some success stories of the workers themselves or the people that they are mentoring. So I think that will be really important for broader application sustainability of this. You know, the credible messenger stuff works really well when something's going down right now and you gotta resolve something. But if you don't have, if it stays there, nobody's going to see it. And often, when they do see it, it's not associated with good things. You know, it's after the fact somebody's got shot and you're having a vigil with them. Or, they're seeing him with a crowd of people who they are scared of. So we need to find ways to bring this program and the workers in more positive light.
And I would agree with that as well, and I would say that that's definitely one of our lessons learned. You know, how do we publicize the work in a way that makes sense? I think historically what we did was we relied on the data. You know, we really thought if we were evaluated, if we were shown to be successful, that literally no one could say no to this, right? And it didn't translate that same way. So that's a big push now. And how do we communicate this work in a way that makes sense? And how are we proactively talking about this instead of after an incident occurs or after we're like begging for funding?
Thanks a lot for a great session this afternoon. This last conversation reminds me that I was really struck by the notion of changing the frame to what happened to you, not what's wrong with you. And that'll be very helpful personally going forward, so thank you for that. But is there a sort of a juxtaposition with that kind of thinking with what I think I heard Daniel say, which is the police saying bad guys with guns? And so how do we, if that's true, how do we bridge that?
Well, I think you nailed it, Andrea. I think it is a challenge. That is definitely just sort of baked into a culture in law enforcement that there are at least some individuals out there that they are bad, okay? And the reason some people sign up to be a cop is to protect so-called good people from bad people. Now we know that's, you know, there's far more complexities in that, but I think it's probably our biggest challenge. But again, I think the way you move beyond that is really to humanize this a little bit, to show particular examples of transformation. And, you know, I'm in both American Public Health Association and American Society of Criminology. Over the past 20 years, that second group, the criminology group, they are talking more like public health than I've ever heard in my life. And so there is change afloat. It's not as fast as we would like, but I do think that there is more and more recognition that this sort of very simplistic bad guy, good guy thing doesn't get you nearly as far as thinking about what are our problems that we need to solve. And typically, they're complex problems that we're going to need all hands on deck ways to support communities and people to be safe.
Do you think if you were talking about trying to counter the NRA, it would be good to say we're just taking guns away from bad guys? Maybe there was something more political than not appreciated. I hadn't thought of that before. Maybe it's just more politically.
Well, as far as, what Fred Biefeld was saying is, he doesn't want to say he's just going to go after guns because there's law-abiding gun owners who are not causing anybody problems, right? So what he was signaling was it's not like we're creating war on guns or gun owners in Baltimore. We're going to focus on people who are shooting people. And I know that Gary Slutkin in particular and others will say we need to focus on the behavior, the shooting behavior, as opposed to who it is. But that's challenged when you sort of get down to very specific policies. And sometimes those policies will address laws or their application based upon what someone has done, So, but again, I think there is more resources and policy direction for getting away from this notion that someone is a criminal, always a criminal kind of mindset, and thinking about, we don't even call them ex-offenders anymore. We call them returning citizens, right? So there's a variety of ways within these systems where we're trying to acknowledge that we're talking about human behavior and not just one set of is good or bad. But again, it gets complicated when you're in these positions having to apply very specific policies.
Well, I also think there is a policy place that we societally haven't paid enough attention to at all. And it really leads to giving people the capacity to be good or bad, and having people really have the capacity to make good choices. And we invest the least amount of money that we have in our most vulnerable children. If you look at any child maltreatment government-run Department of Human Services group, I used to take pediatric residents into the Children's Protective Services room, and there would be 85 carols of kids, of maybe 25-year-old education majors or business majors who have caseloads of 50 kids, and they're supposed to be managing this. And we haven't invested in that. And investing in preventing ACEs, investing in giving kids resiliency, it's very possible. We know that there's biochemical changes. We know there's genetic changes. We know if you give someone one good, strong, safe adult longitudinally, that resiliency happens. We know all of that, and we act on none of it. So until we invest that way downstream, then I think we're always going to have a hard time not being reactive.
Any final questions? All right, well, please join me in thanking our panel.